Perfect.
Okay. Hello, everyone. My name is Melita Petrossian, and I'm here to speak about updates in the diagnosis and treatment of Parkinson's disease. I have research funding from Sun Pharma, Cognition Therapeutics, and previously Praxis, and I'm a consultant for Can Do Health, but these are not relevant to today's talk. Today, we'll be talking about the clinical features of Parkinson's disease, related conditions and mimics, diagnostic tools that are available, as well as treatment options. So to start with the case, we can imagine a 55-year-old right-handed woman with rheumatoid arthritis and chronic lumbar spondylosis who presents for tremor onset around age 25 with more recent development of rest tremor and anxiety. Her exam shows postural and action tremor, but also rest tremor and some slowing of gait and fast finger movements. She does have mild joint swelling noted on exam. Her gait shows normal arm swing, but she does have some stooped posture and some mild shuffling. And she comes to you asking her to please tell her she does not have Parkinson's disease. So I see many patients with tremor, and I always, in my mind, as I'm examining them and as I'm questioning them, I'm always thinking back and forth between how far does this fit into the box for essential tremor, which is much more common than what we'll be talking about today, which is Parkinson's disease. So I'm always listening and looking for anything subtle that is a sign or symptom that concerns me for Parkinson's disease. So in this case, she has shuffling and stooped posture as well as some rest tremor, but the degree to which her slowness or smallness of movements is actually neurological versus from her joint condition of rheumatoid arthritis isn't clear from the description. So I'll be looking for other signs of what's called bradykinesia, meaning slowness or smallness of movements, such as hypophonia, dysarthria, hypomimia, which is also known as masked facies. And looking at her handwriting will be very helpful to look for any decrement in the amplitude of the handwriting as she goes. In addition, I'll be looking for any rigidity on her exam, as well as more specifically in her gait, whether she has any asymmetry of her gait stride, any freezing of gait, postural instability, or reduced arm swing while walking. She may also describe, and I will be asking about any non-motor symptoms such as fatigue and constipation, but these of course are fairly non-specific. And so more specific questioning would be regarding any anosmia or REM sleep behavior disorder. REM sleep behavior disorder refers to an abnormal movement during REM sleep. REM sleep is categorized by a paralysis of the body other than the eye movements. That's why it's called rapid eye movement sleep. And of course, it's when we dream. But when patients begin to enact their dreams with behaviors such as kicking, punching, yelling, or even jumping out of bed, and on sleep study, that can be confirmed to occur during the REM sleep epoch, that is concerning for REM sleep behavior disorder. REM sleep behavior disorder, when idiopathic, is highly concerning for the subsequent development of Parkinson's disease or other Parkinson's-related conditions. Other more specific symptoms that can precede or co-occur at the beginning stages of Parkinson's are orthostatic hypotension, as well as anxiety and depression. Other non-motor signs and symptoms of Parkinson's may occur at other stages of the disease, such as insomnia, dysphagia, urinary symptoms, and even cognitive decline and even dementia. In typical Parkinson's disease, the onset of the cognitive decline should be at least 1 year after the onset of the motor symptoms. Later stages of Parkinson's can include hallucinations and delusions, and patients can also present impulse control disorders such as reckless spending, overeating, gambling, and reckless spending, as well as sexual misbehaviors. But these typically occur in conjunction with the use of dopaminergic agents. To be specific, we can use the movement disorders criteria for the diagnosis of Parkinson's disease. the most important feature is the presence of bradykinesia without some other cause explaining it, and at least one of the following: rest tremor or rigidity. But the presence of response to levodopa, the loss of sense of smell, and levodopa-induced dyskinesia are supportive criteria. We'll also be looking for any red flags that suggest an alternative diagnosis, such as cerebellar ataxia, eye movement abnormalities, loss of language, or Parkinsonism only in the legs. The patients often come to me with various terms that they've been told by other physicians or neurologists, which they get confused about. They might get told that they have Parkinsonism, but not Parkinson's disease, or a Parkinsonian syndrome, but not Parkinson's disease. So to be clear, Parkinsonism refers to the physical appearance of Parkinson's disease, which refers to the slowness or smallness of movements, known as bradykinesia, rest tremor, and or rigidity. But a Parkinsonian syndrome is any neurological condition with Parkinsonism, and Parkinson's disease refers to the pathological condition that is the most common cause of Parkinsonism. Atypical Parkinsonism is also known as Parkinson's plus, meaning that there's features of Parkinson's plus other things, such as myoclonus, cerebellar ataxia, or dementia. And people often ask me, well, do I have Lewy bodies? And it, I think, terrifies patients to hear that, yes, everybody with Parkinson's disease has Lewy bodies, because they hear the term dementia with Lewy bodies, and that's a more complicated situation, sometimes referred to as atypical Parkinsonism. So Lewy bodies refer to the pathological features that are seen in the brains and nerve cells of people with Parkinson's disease and other related conditions. And they are foremost made consist of alpha-synuclein, the abnormal form of which misfolds and clumps together, forming Lewy bodies. So as far as accuracy, it's not bad, 80, 90% of patients with Parkinson's disease in life have their diagnoses confirmed on autopsy. But it can be difficult, especially in early stages, because often the signs can be very subtle. And so diagnostic accuracy does improve with time. It improves with seeing how patients do with levodopa, looking for levodopa-induced dyskinesias. But there are prodromal stages of Parkinson's disease that may include mild symptoms that don't rise to the level of the Movement Disorders Society criteria. And more recently, the Movement Disorders Society is considering the development of what are called biomarker or biological bases of the disease, as opposed to clinical markers of the disease. So really viewing the disease as when the changes occur in alpha-synuclein, Lewy bodies, and neurodegeneration, rather than viewing it purely from its clinical forms. And primarily what benefit we have in Parkinson's disease is the specificity of REM sleep behavior disorder and anosmia, which can predate the motor symptoms of Parkinson's for many years and are very specific. So moving on, it's, a lot of my patients will ask me, how do you know I have Parkinson's? How do you know I don't have Parkinson's? The case that I referenced earlier of a patient with longstanding, what sounds a lot like essential tremor plus rheumatoid arthritis, can make the exam kind of messy or muddy. So primarily we're relying on the exam and the history for the diagnosis. But sometimes the symptoms and signs like tremor can be intermittent, they can be quite subtle. Arthritis, shoulder injuries, and back issues can mimic bradykinesia and shuffling gait. Sometimes patients look better on exam in the clinic than they do at home. Because a lot of symptoms of Parkinson's improve with conscious awareness or conscious attention to the movement. So patients may sort of deliberately walk with improved arm swing or posture when they know that Dr. Petrossian is watching them walk down the hallway. Whereas their family member may protest that they don't look quite so good at home, that they're shuffling or they look more stiff at home. Another issue I think I've come across is I find that a lot of physicians get really nervous about making a diagnosis and they don't want to label somebody. So they might use these terms like Parkinsonism because they don't want to, burden somebody with a diagnosis. And then other issue, of course, is that Parkinsonian syndromes can overlap and appear similar in early stages. So what are the conditions or mimics that can contribute to the clinical appearance of Parkinsonism? Well, of course, the most common form of Parkinsonism or cause of Parkinsonism is Parkinson's disease itself. We'll get into dementia with Lewy bodies in the next slide. So that's a little bit complicated, but there are atypical forms of Parkinsonism, also again known as Parkinson's plus, such as multiple system atrophy, which is a much more rapidly progressive condition and often involves cerebellar atrophy, cerebellar ataxia, or just more significant, more prominent autonomic dysfunction, such as orthostatic hypotension, dysphagia, and constipation. Separately, there is progressive supranuclear palsy, PSP, which is not a synucleinopathy, but a tauopathy. So it is caused by a very different underlying pathology. But the clinical syndrome is very similar to Parkinsonism. Features of PSP that are more specific to PSP include early falls, rapid progression, and especially eye movement abnormalities, specifically delayed vertical saccades. So a very key part of my exam is to look at eye movements and to ask them to look left, right, up, and down. Another cause of atypical Parkinsonism, also a tauopathy similar to PSP, is called corticobasal syndrome. The hallmarks of CBS are more asymmetric onset of symptoms, much more severe akinesia, meaning almost to the point that the hand is just no signals are getting through and that arm is not moving at all. And a lot of myoclonus and what's called alien limb, which is an involuntary movement. Another feature of corticobasal syndrome is apraxia, which is defined by the inability to do a task without weakness per se. So you might ask them to give a thumbs up or tie their shoes and they struggle quite a bit. And of course, corticobasal syndrome can be manifested by cortical signs such as aphasia and other cognitive changes. Then moving on to vascular Parkinsonism, this should be able to be differentiated via MRI. We might see clinically more of a lower limb predominance, so legs more involved than arms, lots of falls, slowness, shuffling without as much upper body involvement. Drug-induced Parkinsonism, of course, very common, very important to ask about whether patients are taking dopamine blocking medications such as Reglan, Compazine, and Abilify is very popular now with the psychiatrists, so need to ask about those types of medications. Normal pressure hydrocephalus also can be diagnosed via MRI and would also feature cognitive and urinary dysfunction, and should not involve as much of the rest tremor or the more Parkinson-specific symptoms such as REM sleep behavior disorder and anosmia. What else can cause tremor? So essential tremor is the most common cause of tremor, and severe essential tremor can show rest tremor, as is shown in this case that I presented to you. Medications, of course, can cause tremor, and dystonia can cause a combination of an action and rest tremor. And then, of course, there are the more common classic, age-related changes such as balance issues, orthopedic issues. I always ask about alcohol intake because that can contribute to cerebellar degeneration, and neuropathy can cause shuffling gait, imbalance, and falls. So to speak more specifically regarding dementia with Lewy bodies, also known as Lewy body dementia, this gets confusing because as of recently, it's been considered a separate diagnosis, thought to be really separated from Parkinson's disease. But more recently, the Movement Disorder Society consensus opinion that it is a subtype of Parkinson's disease because the pathology is the same and there's so much overlap between these two subtypes of the condition. It's kind of like two ends of the spectrum. It's a little bit still controversial. Not everybody quite believes that, but the concept would be, is it something that's starting more widespread with cognitive decline first and foremost, and some Parkinsonism, visual hallucinations, transient alterations of awareness or attention, and REM sleep behavior disorder? Or is it starting really with Parkinsonism, meaning the motor symptoms, and the dementia or visual hallucinations are occurring much later in the course of the disease? In general, unfortunately, there isn't a separate treatment for dementia with Lewy bodies that compared to Parkinson's disease. The difference is really regarding the prognosis and some of the management concerns, such as really being much more careful with neuroleptics, because DLB patients are classically very sensitive to these medications, and being a little bit more cautious with levodopa because they tend to have more side effects and less responsiveness. Moving on, I like to give an analogy of how I think of the two conditions as the different ends of the spectrum of the same disease itself, as the analogy of how the difference between a DVT and a PE. They're really the same underlying pathology, and the treatment may be very similar, but the manifestation may be different, and the morbidity, mortality may be different. Treatment of dementia with Lewy bodies generally should involve a trial of an acetylcholinease inhibitor if that's possible, because they actually tend to do well with that treatment compared to other dementing conditions. And if there are a lot of movement symptoms, such as shuffling or bradykinesia, levodopa can be trialed gingerly, and there's a lot of emphasis on exercise, physical and occupational therapy, and speech therapy. And there are some current and upcoming clinical trials that hopefully provide more treatment. So talked a bit about vascular Parkinsonism and normal pressure hydrocephalus. One of the key points about vascular Parkinsonism is that the strokes are often silent, meaning that the patients aren't aware of having a stroke history. The patients can sometimes respond to levodopa, so it's worth trying. And there can be an overlap, of course, because really we don't see a lot of pure pathology. A lot of people who do have idiopathic Parkinson's disease will also have some degree of vascular burden, on autopsy. So, there's often an overlap with these things. As far as NPH, the classic term magnetic gait really refers to a gait apraxia, like more of a difficulty picking up the feet, which can sometimes look similar to the Parkinson's shuffling gait, but there is really a difference that's seen clinically in some cases. Of course, the diagnosis for this would be with a large volume spinal tap or a lumbar drain trial, and then treatment is with a ventricular parietal shunt. So MRI is often done in people who are presenting with symptoms of Parkinson's disease, but isn't always required. If you have somebody who is looking very straightforward, they're presenting with rest tremor, asymmetric bradykinesia and rigidity, they have anosmia and REM sleep behavior disorder, it's reasonable to forego an MRI if you make a clinical diagnosis. But for anybody who's presenting with dementia or cognitive decline or any atypical findings, it's really important to do an MRI. So on the left, we see the difference between a normal brain and an NPH brain with ventriculomegaly, as well as you can see the crowding of the sulci here. I find that depending on which radiologist is looking at the MRI, a lot of times people are overreading ventriculomegaly, because ventriculomegaly is very common with people who have central atrophy. So you really want to look at, the Evans ratio, but also you're looking for crowding and more of those clinical features. And then, when in doubt, one can do other diagnostic testing for Parkinson's disease or refer for a lumbar drain trial. Vascular disease, of course, we might see the white matter predominantly involved subcortically, fairly symmetrically, sometimes with a wedge-shaped, appearance of an old stroke. In patients with PSP, we're looking for what's called the hummingbird sign, which refers to midbrain atrophy. You can see an asymmetric ratio between the midbrain and the pons fairly preserved. In multiple system atrophy, the classic textbook sign is the pontine hot cross bun sign you can see here. From pontine atrophy, there's quite a bit of cerebellar peduncular atrophy here and cerebellar atrophy as well. There are some studies that are looking at utilizing MRI as diagnosing Parkinson's disease itself, but I find that it's not really as most MRI scans aren't quite as detailed as this one is. Usually you need a really high Tesla, sometimes even a 7 Tesla scan with susceptibility weighted imaging to find what's called the swallowtail sign, which is the substantia nigra showing up normal versus absent in Parkinson's disease. So I don't really rely on MRI as a diagnosis. Generally, I tell people that the MRI will usually be either normal or normal for age, and I'm really looking to rule out these sort of mimicking conditions if I'm obtaining an MRI. Also important is that even if we look at that swallowtail sign, it does not differentiate Parkinson's and atypical Parkinsonism. Did I skip too much? No. Okay, so DAT scan. So DAT scan became available in 2011. It is very commonly used now for diagnosing what is called Parkinsonian syndrome, of course, because it cannot differentiate between Parkinson's disease and atypical Parkinsonism. But accuracy is very good, 80 to 90% between Parkinson's disease and essential tremor. It can also sort of, if it comes back positive, that should rule out drug-induced Parkinsonism and vascular Parkinsonism. It is a brain SPECT scan with a dopamine transporter that is being targeted. So we see a reduction in the uptake in patients with a Parkinsonian syndrome. In this case, on the left, we see a normal, what's called comma-shaped scan, and then on the right, it's kind of a circle-shaped. And you can see there's also asymmetry here, where there's more uptake in the right caudate and a little bit less uptake in the left caudate and no uptake in the putamina bilaterally. A DAT scan is not used clinically to give prospective information as far as, how bad is the DAT scan, but there are quantitative DAT scans available called DAT Quant, and it is being looked at in research as a potential biomarker for various clinical trials to see if you can differentiate, at year 1 versus year 2 or 3, how their DAT scan looks in comparison. More recently, there has been some real interest garnered in looking directly for abnormal alpha-synuclein, meaning that misfolded or phosphorylated alpha-synuclein. So far, it hasn't been particularly successful in blood, but there has been availability in doing seed amplification assays in spinal fluid. Specifically, what is done here is that a sample of the patient's CSF is mixed with normal protein, and if there is misfolded alpha-synuclein in the sample, it triggers aggregation, which can then be detected over the course of 5 days using a fluorescent probe. So on the right here, we see 4 patients with Parkinson's disease and 4 control patients CSF. And the controls are in red, the Parkinson's are in black. And there was a very dramatic, clear presence of that aggregating alpha-synuclein in the Parkinson's disease. In clinical studies, the sensitivity has ranged between 88 to 95%. Specificity is quite good, 97 to 100%. But again, as I mentioned before, it cannot differentiate between synucleinopathies, for example, Parkinson's versus MSA, or whether somebody, and also I will say what kind of has been really interesting in the community has been the fact that you can actually detect these abnormal forms of alpha-synuclein using these SAA tests in people with what's called prodromal Parkinson's disease, meaning that those with just REM sleep behavior disorder or anosmia, even before the development of any motor symptoms. So that's very promising as a potential prospective, or not prospective, but preventative biomarker for evaluating people who are at risk of Parkinson's disease before they've developed it. So overall, the sensitivity was quite good. But when patients with Parkinson's had anosmia, meaning loss of sense of smell, the sensitivity was much better, 99%. Those without anosmia, the sensitivity was quite a bit worse, 78%. And the specificity, meaning healthy control, was 96%, quite good. Also of interest was a study looking at people who had no Parkinson's or prodromal symptoms, but had genetic risk factors for Parkinson's disease. And 8% of those were positive in these tests, suggesting that they are more at risk for developing Parkinson's disease. Beginning in 2020, the SYN1 biopsy became available for another way of detecting phosphorylated alpha-synuclein, this time in the dermal nerves. This does not require spinal tap, so patients tend to prefer this type of testing. 3-millimeter biopsies are obtained, so from the shoulder, near the knee, and near the ankle. Again, very similar accuracy, 95 to 99%, but also cannot differentiate between the synucleinopathies of Parkinson's disease, MSA, REM sleep behavior disorder, and pure autonomic failure. Looking at an autopsy series, found that there is a lot of patients who have mixed pathology. So on the right here, you can see that 85% of people who in life were diagnosed with Parkinson's disease had Parkinson's pathology only, but some patients also had vascular lesions, as well as tauopathies. Whereas in people who had atypical Parkinsonian disorders, meaning they were diagnosed with multiple system atrophy, there was an overlap with other pathological diagnoses, such as 40% just Lewy pathology in MSA. Basically, the point of this study was that there's a lot of mixed pathology. About 25% of people with diagnoses of Parkinson's also had Alzheimer's pathology. And 4% of people who had Parkinson's disease actually had MSA on autopsy. So I'm going to pause and tell you our secret code, because we're moving on to discuss treatment. And the number one treatment I always recommend is exercise. So that is the secret code. It is exercise. It is, in line with the most important thing that I want you guys to know from this talk is exercise. Very important for the treatment of Parkinson's. But before we get into that, we will talk about medications. So medications for the motor symptoms of Parkinson's disease. Now, I don't have enough time in this talk to talk about the management of non-motor symptoms. It's very important to manage non-motor symptoms such as insomnia, anxiety, depression, constipation. Very important discussion, but not really. I don't have the bandwidth to discuss that during this talk. So we're really going to be specifically talking about motor symptoms. So of course, the focus is really going to be on dopamine. Dopamine is really not the whole story of Parkinson's disease, but for the purposes of this lecture, it might feel like it. So levodopa is the precursor to dopamine. Dopamine can't be administered orally without causing a lot of hypotension. So it's given as levodopa, which gets converted in the brain into dopamine. It's also given with a dopa decarboxylase inhibitor, most typically in this country, carbidopa. But the active portion of the drug, if you will, is the levodopa. So if you look at the ratio 25 to 100, that's a 1-to-4 ratio of the carbidopa to levodopa. Levodopa has many names: L-Dopa, Sinemet, Stalevo, Rytary, and Brija. We'll get into that in a bit. So you'll forgive me if I use the term Sinemet because it has 3 syllables instead of 8, carbidopa, levodopa. But the concept is that the levodopa acts, gets converted in the brain into dopamine. Dopamine acts on the dopamine receptors. But we can also act on dopamine receptors using dopamine agonists, such as pramipexole, ropinirole, and rotigotine, which is the Nupro patch. Apomorphine is not used nearly as often anymore. And then, of course, ways to boost dopamine are reducing the metabolic breakdown of dopamine. So MAOB inhibitors specifically act on dopamine. And so by inhibiting those, we can improve the presence of dopamine at the synapse, so specifically rasagiline, selegiline, and safinamide. I will state that these are MAOB inhibitors, so they don't actually carry most of the risks of the non-selective MAO inhibitors, which also act on MAOA and can cause tyramine crises and things like that. So there really aren't any diet restrictions for patients on MAOB inhibitors. They don't need to be stopped in advance of anesthesia. There's much fewer risks for serotonin syndrome. So when they're used at the low doses that are used in Parkinson's disease. COMT inhibitors such as entacapone, Comtan, and Stalevo, and opicapone, which is on Ongentys, can also improve the dopamine at the synapse by reducing the metabolism of levodopa. So these don't do anything on their own. They're only useful as adjuncts to levodopa, whereas rasagiline, selegiline, can be used as monotherapy in patients with really early stage mild treatments if somebody does not want to get started on levodopa just yet. So levodopa does need to cross the blood-brain barrier to get converted into dopamine. And the carbidopa blunts the dopa decarboxylase, therefore allowing for more dopamine in the brain. So that's why you have to have both of them together. Some patients find that they're having nausea with the medication, so I always start with a low dose. I increase very slowly. I actually ask people to start by taking it with food, and over time, as they're tolerating it better, then I ask them to take it on an empty stomach. It is more effective on an empty stomach, so it is important eventually for them to be keeping an eye on their meals and their oral intake. There are multiple formulations of levodopa, including immediate and controlled release Sinemet. Parcopa is really not easily found anymore, so I should take that off the list. That was an orally disintegrating use. Rytary, which are extended release capsules, and Divi, which is just the same immediate release, just in easily divided tablets. Of course, levodopa is the most effective medication for Parkinson's disease. But there are patients who, as the disease progresses, will develop dyskinesias and motor fluctuations. Now, dyskinesias are quite common, but they're not as disabling or as concerning as might be considered. So specifically, patients with very mild dyskinesias may not really be aware that they even have dyskinesias. I have many patients who have a very mild little head bob like this, and I'll ask them about dyskinesias, and they'll say, no, I don't have any dyskinesias, and they're really just not aware of it, and often even their family members not aware that those are considered dyskinesias. Sometimes dyskinesias can be a little bit more kind of wiggly, a little bit more apparent, for example, to the family member, but still not particularly apparent to the patient. And if people are having more severe dyskinesias, they may notice them and be somewhat bothered by them, but be much more bothered by the symptoms of Parkinson's, the slowness, stiffness, rest tremor, and therefore they really often will tolerate the dyskinesias instead of dealing with the Parkinson's symptoms. For patients who are older or who have dementia, especially when their dementia and Parkinsonism sort of are coming at similar timeframes, there can be side effects of confusion and hallucinations. Generally speaking, if patients have been on levodopa for many years and tolerating it well, and then they subsequently developed confusion or hallucinations, I don't see the likelihood that the levodopa is to blame unless there's been a recent change in their dose. So, complications of treatment with Parkinson's disease. So, on the left here, we have the earlier stages of the disease where patients can take 3 daily doses of levodopa and maintain a good degree of controlled Parkinson's motor symptoms over the course of the day. So, when people are feeling like their symptoms are well controlled, we call that being on. So, the the other way to frame it is the meds are working, they're not having as much slowness, stiffness, or tremor, um, and they're not feeling, quote, off. So when medications wear off, that's when people will feel slow, stiff, stuck, but they may also experience non-motor symptoms such as anxiety, fatigue, or even cognitive confusion. So when patients have, let's say, too much levodopa, they're more likely to experience dyskinesias. But these slides are very simplified. It's really much more complicated than this. It's not simply the up and the down of the dose, but there can be a lot of other factors that contribute. Oftentimes, in earlier stages of the disease, unless the patient has forgotten their dose, they may not notice when their dose kicked in or wore off. But as the years go by, they may start to notice that the medication doesn't last as long. Maybe it's only lasting 3 hours and they're, not due for their dose for another 2 hours. Or maybe it's taking longer to kick in. And often patients will have what are called peak dose dyskinesias, but some patients will have dyskinesias at any time of day with any dose. So as you can see on the right side of the screen, as the years have gone by and the disease has progressed, they're having much less time in that well-controlled on state and more time either off or on with dyskinesias. So what to do? Well, there are different forms of levodopa that can be given. Specifically, there is a extended release form called Rytary, which comes in 4 different strengths and has microbeads within it that have both immediate and extended release components. So it has a more smoother release over the course of the day. Though they come as larger capsules than the tablets, they can be opened and sprinkled onto applesauce. And I always advise people it takes a little bit of time to get used to it. It is not dose equivalent to Sinemet. So if you come across a patient who is in the hospital and your hospital doesn't have Rytary, which is very common, it is not dose equivalent. Make sure that the pharmacist is helping, or even the patient themselves might be able to guide on the, getting the Rytary that to continue the home dose, or if it has to be converted into immediate release, that needs to be done with a pharmacist because they are not dose equivalent. Very, very new news, hot off the presses. Just 5 days ago, the FDA did approve a newer, longer acting form of levodopa called, weirdly, Crexont. They don't call me to ask me about the names. I wouldn't have chosen that one, but that's what we have, Crexont. So this was, again, formulated with the same carbidopa levodopa, but just a different, longer acting form. So 3 times a day dosing showed a similar amount of on time as 5 times a day dosing with the immediate release. And each dose provided an additional 1.5 hours of on time compared to the immediate release. Now, this was not compared head to head to Rytary, so I don't know how it will do with that. But, we'll see as we start using it. I've definitely used Rytary and found some patients do really well. They've noticed quite a difference compared to the immediate release. Others, not so much. So there's always things that can be tried. But again, Rytary, really important to get the dosing right because I've seen a lot of people where they're severely underdosed or sometimes even severely overdosed. Other forms of levodopa include the inhalable levodopa, Inbrija. Now, this can be really good for unpredictable or sporadic off time because some patients, they don't have that predictable, I take it, I have to wait an hour, or I take it, it wears off at 4 hours. Sometimes they're normally fine, and then they'll have one dose where it just didn't seem to kick in at all, or it was very late or very early wearing off. So that's where an oral inhalation is helpful. So this is a capsule that is not taken orally, it's inhaled via the mouth. And it works very quickly. It lasts about 1 to 4 hours, but there's no carbidopa in it. So people still have to take their oral doses of carbidopa levodopa, and they have to kind of get used to using it because a lot of people will cough when they first start using it. So I always tell people to slow down, take slower breaths, even shallower breaths if necessary, and drink water before and after. And of course, this isn't a preventative. This is just like a rescue drug, if you will. Since 2014, in the United States, there has been a levodopa intestinal gel infusion, which is called Duopa, that gets infused through a PEJ tube. It does reduce off time by bypassing the stomach and providing a continuous 16-hour administration, providing the same benefits as levodopa, but a smoother concentration over the course of the day. But complications can include tube malfunction, ileus, pulled tube, neuropathy. Usually that's only in the first 2 weeks. We are expecting the FDA approval of a patch pump form of FOS carbidopa, FOS levodopa, so the prodrugs of carbidopa levodopa. But though the phase 3 clinical trials have been completed and submitted, the approval is pending some further evaluation of the third-party issues. So there was an improvement of on time by about 2 hours. This will be going kind of like an insulin pump into a patch. And so there may be some issues with skin irritation and pump fatigue, but we'll see how things go going forward. So the other thing that's important to mention is management of dyskinesias. So amantadine has been available off-label for many years, decades even. Amantadine regulates dopamine release and helps mitigate glutamate toxicity and helps mitigate dyskinesias while still improving on time in people with Parkinson's disease. But the specific medications that are FDA approved that have the labeling, that is, are Gocovri and Osmolex. Those are long-acting forms of amantadine. So it's the same old amantadine from decades ago, the same old antiviral med, but because they're extended release formulations, they got the FDA approval and stamp, and they have brand names now, Gocovri and Osmolex. But besides that, the other medications on this list are primarily levodopa based. Ongentys, as I mentioned before, is opicapone, which is a COMT inhibitor. So there have been a lot of advances really in the past decade of new medications for motor symptoms of Parkinson's disease. In the interest of time, I'm going to move on and talk about surgical treatments of Parkinson's disease. Deep brain stimulation surgery has been available since the mid-90s for treatment of tremor, and then a little bit later developed for the tremor in Parkinson's disease and other symptoms of Parkinson's disease. So DBS can help for tremor, improve on time, and reduce dyskinesias, but it doesn't help for other like non-motor symptoms of Parkinson's. It does not help for dementia. It doesn't help for patients with atypical Parkinsonism. So really, it's important to choose the right candidate for the surgery. Patients who are levodopa responsive but with off time or dyskinesias, or those with medication refractory tremor, absence of dementia or severe depression, and MRI relatively normal for age, should expect to have a good improvement in their symptoms, specifically about a 70% reduction in tremor and a 5-hour improvement in on time and about a 60 to 70% reduction in dyskinesias. It does require the placement of electrodes and a pulse generator under the skin. and it does require programming. But what's nice about it is that it can be adjusted, it can be placed bilaterally, and it can be placed in either the GPI or the subthalamic nucleus, or in some cases where the tremor is the most concerning, in the VIM of the thalamus. And as I said, this can be utilized bilaterally. More recently, some advances in the surgical treatment have included what's called brain sense, which is where the pulse generator actually picks up the data coming from the brain signals, specifically a type of wave called a beta wave or a beta band. And the beta band is correlated with the Parkinson's symptom, with tremor. It's correlated with periods of what's called off time. So by picking up on the beta signals, currently what we're able to do is utilize that to target the programming more specifically. We're hoping or expecting that in the future we may be able to have closed loop stimulation, meaning that the stimulation will only kick in when the beta band is detected. But for now, that's not how it's used. It's still conventional DBS, but just that we have that available information to guide how we do the programming. Other companies that do DBS other than Medtronic are Abbott and Boston Scientific, and they have made progress as well that has allowed for more healthy competition between these companies and a lot more advances than in the first couple of decades. So there are directional programming, meaning instead of a ring electrode simulation where the electrode is divided into 3 segments and you can point the stimulation towards a lateral, let's say, side by utilizing just a third of the electrode. That's been very helpful. So we'll talk a bit about focused ultrasound. So specifically, the earlier development was focused ultrasound thalamotomy, meaning essentially a heat lesion of the VIM of the thalamus to reduce tremor. So we kind of went full circle. We started with surgery, which was creating lesions in the brain. And we moved away from lesioning surgeries when DBS came about. And now we're back to lesioning, except we're doing it without incisions. So the focused ultrasound, I always say it's 1,000 beams of ultrasound focusing on a small voxel of brain tissue and creating a heat lesion. And I always give the analogy of if you take a magnifying glass and you focus the rays of the sun, you can burn a hole in a piece of paper. So they are MRI guided because the MRI is not only localizing, but it's also doing thermography. So during the procedure, the patient is awake, their head is in a frame, and the MRI is measuring the temperature increases with each sonication. The patient is being evaluated for improvements in tremor, as well as in any side effects, such as visual symptoms, facial pulling, tingling, speech issues. And when the surgeon is satisfied with the location that they have the most benefit and no side effects, then they'll give further sonications and then the lesion will become permanent. But at the beginning of the procedure, if there are side effects, that the target can be shifted slightly by a millimeter, left or right. So what are the data? So on the right, you see focused ultrasound with thalamotomy, meaning targeting the VIM of the thalamus. And this is done both for people with essential tremor and Parkinson's disease. And in this study, this was a 5-year follow-up study. Now, these are all open labeled here, but you can see that the hemi, meaning one side, because they were doing unilateral treatment, the opposite side clinical rating scale for tremor was significantly reduced at 1 month in the median, but the benefit lasted quite some time. So even at that, 3-year mark, still extremely good, starting to have a slight worsening in the 4 and 5-year mark, but still very, very improved compared to the baseline. On the left, we have the study from the New England Journal that was looking at Pallidotomy, meaning that they were targeting the globus pallidus for treating not just tremor, but also other symptoms like movement, like slowness, stiffness. And the way this is reported out was with what percentage of patients had at least a 3-point improvement, which I think is okay, but I mean, I would like to see more than 3 points improvement to be considered response. So here the scale is on the Movement Disorder Society Unified Parkinson's Disease Rating Scale, which is how we look for slowness, stiffness, tremor, and they were only looking at the treated side because again, this was unilateral. And so, you know, a significant percentage improvement of people had at least a 3-point improvement, but that doesn't really tell us what degree of improvement they had. There are some side effects with focused ultrasound, namely dysarthria, visual disturbance, and facial weakness. Usually these are transient, but they can a very small percentage can persist at the 3-month or 12-month mark. So one would be considering focused ultrasound as opposed to DBS. Well, if somebody's really opposed to having brain surgery, I don't call focused ultrasound non-invasive because it's a brain lesion. I call it non-incisional, but you don't have to deal with hardware. You don't have to worry about multiple procedures. It can be done bilaterally, but there are more risks of slurred speech and gait issues with that. So I find it more useful for patients who are really more fragile when it comes to doing a DBS and really want a more rapid outcome. So exercise, very, very important, very significant benefit that the patients themselves will notice. So what makes my job easy is that I don't have to constantly tell them to exercise when they can tell the difference. So they see the improvement with physical therapy, with high intensity cardiovascular, especially with strength training. But what's nice is that there's so many different types of exercise that are helpful. And so it doesn't have to be any one thing. You know, everybody asks me about boxing, but it doesn't have to be boxing. I mean, Pilates, yoga, dance, ping pong, tai chi, all of these things are really beneficial because in addition to providing a little bit of cardio, a little bit of strength training, they're also exercising the brain. So the brain has to utilize its mirror neurons. It has to learn something new, connect brain to body, and that's called cognitive physical dual tasking, makes a huge difference. Speech therapy, swallow therapy can be very important and very helpful in improving quality of life. Occupational therapy can be really helpful with assisting with how to, get by with certain symptoms of Parkinson's disease. Sleep is extremely important. So we talk a lot about sleep hygiene, cognitive behavioral therapy for sleep, and there's a lot of evidence for the importance of social engagement, cognitive stimulation, mindful awareness, and meditation for the treatment of Parkinson's disease. So there's a lot of evidence for exercise. What I like to tell people is that exercise changes the brain. It lets the brain use the dopamine more efficiently, so we get less off time, better utility of the medication. It also creates new synapses between brain cells, and it, especially high intensity cardio, releases BDNF, which protects the brain cells and actually reduces transmission of PD pathology in rat models. And then, of course, we know it's really important for bone density and muscle bulk. So it prevents falls and then it prevents injuries from falls. So again, really, really important. This is an amazing study from Corcos where they looked at patients over the course of 2 years. And these were patients who'd had Parkinson's for about 6.5 years. These are, older people, 50 to 70 years old. And they had them either do progressive resistance exercise, which was essentially strength training, but with very incremental increases in the resistance, versus a modified, kind of milder, gentler exercise program like stretching, balance exercises, breathing. And they only did it twice a week, but both groups improved quite rapidly. If you look at A, you can see the mean change from baseline in the UPDRS score, meaning their motor symptoms, significant improvement of 6 points in the first 6 months on average. But the milder exercise program, they kind of crept back up to their baseline at the 24 months mark. But that's still really great because they didn't progress. They actually went back to their, original baseline. But the patients who were doing the progressive resistance exercise, they actually continued to improve from their own baselines. And that's at 24 months for a neurodegenerative condition. I mean, that's really impressive. Another really key point here in box B, you see the amount of levodopa that people were taking. So yes, they did take more levodopa as the months went by, but at least at the 18-month mark, the people who were doing the progressive resistance exercise needed less of an increase of medication than those in the modified fitness count. So again, I like to tell people exercise is like a drug for Parkinson's, really important. When people tell me they're not doing well, they've been stable for a while and they started to not do well, first thing I ask them is, are you exercising? And often they'll say, you know what, I wasn't, I was vacationing, I did this, I kind of slacked off. I'm like, get back on exercise. I'm not going to increase your meds until I see how you do with exercise or refer you for PT or something like that. Briefly talking about the diet, there's a little bit less data on diet, but there is some association of the Mediterranean intervention for neurodegenerative delay, also known as the MIND diet, as being associated with a lower rate of developing Parkinson's and a delayed progression of Parkinson's disease. It's everything we already know we're supposed to be eating and not eating, right? Like, green leafy vegetables, whole grains, berries, nuts, beans, legumes, fish, poultry, and really lots of vegetables and limiting fried food, fast food, cheese, and butter, and limiting sweets. Now, this particular MIND diet suggests wine. The red wine, I don't quite agree with that, and I don't recommend that for my patients, but it is technically part of the MIND diet that was being studied. And so going to conclusions, the key point here about diagnosis is that most people can be diagnosed accurately based off of clinical findings. But there are many cases where, I'm not sure, like in the case I presented, well, she looked mostly like essential tremor, but she had some things that were a little bit, could be concerning for Parkinson's, like the shuffling or the stoop posture. So in her case, I might have gotten a DAT scan to see whether she had Parkinson's or not. But it's not always necessary to do these types of tests. And we definitely need prospective biomarkers to be able to tell people where they are and where they're going in time. And we don't have that yet. And then as far as treatment, by far the most important treatment to prevent progression of Parkinson's disease is exercise. And I would also include the importance of managing anxiety, depression, and encouraging social engagement, although I don't have as much evidence for that as much as I have anecdotal evidence. And then medications, there's tons of new options, a lot of great developments that have been made. Unfortunately, one thing that does come up quite a bit is the cost associated with these newer medications that can be very difficult. But we try to work around that if we can. And there's been a lot of advances, really even in this past week, August 2024. And then, great advances being made in surgical techniques like TBS and focused ultrasound. And overall, I would say it's very important for patients with Parkinson's to be followed by a neurologist, preferably a movement disorder specialist. And there's definitely data on improving mortality when patients with Parkinson's disease are being followed by neurologists. So I'd advocate for my field there. Thank you for your attention, and I'll be available in September for questions. And these are my references.